Good morning, everybody online. Over here with us. This morning, I have the pleasure of introducing Francisca Base. Francisca is a dedicated pharmacist with a strong academic foundation and diverse professional experience in the pharmaceutical field. She completed a Bachelor of Pharmacy degree with distinction at Northwest University in 2016, where she was recognized with the award for extraordinary achievement in pharmaceutical chemistry and promotion of the subject. She went on to earn her Master of Science in Pharmaceutical Chemistry with distinction in 2018. Her research in this field was published in the Chemical Biology and Drug Design Journal, contributing valuable insights into drug design. In 2023, Franciska further expanded her clinical capabilities by completing the Primary Care Drug Therapy course. She's currently pursuing a Master of Science in Medicine, Clinical Pharmacy at the University of the Witwatersrand, where she continues to explore her passion for optimizing therapeutic outcomes through careful medication management. With professional experience spanning the community oncology and hospital pharmacy settings, Francisca brings a comprehensive understanding of pharmacotherapy across diverse clinical environments. Her key interests lie in drug design and clinical pharmacy, and she remains committed to research and she continues to with the continuous pursuit of knowledge in pharmacotherapy. So thank you. Thank you so much for coming to present to us today.
Thank you for the kind introduction and for allowing me to do this presentation this morning. So today I decided to discuss a very broad and extensive field, drug interactions. So this will probably be, I'm just looking at a few key points just to get us all thinking a bit differently about how we can manage drug interactions and how we can address it accordingly. So the presentation today, so the talking points will include just the basic principles of drug interaction with a bit of more focus on time course and then the mechanisms of drug interactions. So we'll be looking at the four main ones: the GI absorption interactions, protein binding displacement, modified drug excretion, enzyme induction and inhibition, and then just a little bit more detail regarding the GI absorption interactions. So obviously, when you increase your number of drugs that you use, you will encounter more drug interactions. So to assist with evaluating these interactions, it's important to understand pharmacodynamics, so what the drug does to the body, pharmacokinetics, what the body does to the drug, the time course, which I will elaborate on the next slide, and then also the mechanism of the drug interaction, because this knowledge will assist you with how to manage the drug interaction. So time course, meaning anything from seconds to minutes to weeks, where you can see a drug interaction present. So you can, the things that affect your time course, the time of onset of the interaction, the time of the maximum pharmacokinetic and pharmacodynamic effect of the drugs involved, the time the patient is experiencing the adverse response or interaction, and then obviously the most important one, the time for the interaction to dissipate. This will also guide you to decide if you will go for an antidote or rather just symptomatic support. So the determinants of time course is half-lives. So the half-lives of the object drug, so the drug which action is altered, the precipitant drug which causes the alteration. Dosages also plays a big role. If you are dosing in the upper therapeutic limit, you can easily exceed to toxic levels when you encounter an interaction. And if you dose in lower therapeutic levels, you might take longer to see an interaction if you even see an interaction at all. So the drugs can interact with each other, but it has no clinical effect that you can see in the patient. The route of administration is also important. So routes that reach therapeutic levels quicker, like the IV route, will also present with a more rapid onset of an interaction. Other considerations is the parent drug versus the metabolite, meaning if the interaction is caused by the metabolite, you might only see your interaction after a few days even. A good example is theophylline and erythromycin. So the metabolite of erythromycin hinders the clearance of theophylline, but you can only see this after 5+ days of erythromycin use. So usually if the courses are shorter, you don't even see the interaction at all. And then lastly, the pharmacokinetic effects, especially on elimination. So most drugs are dose-dependent eliminated. However, if your precipitant drug counters that elimination process, you can actually push your object drug into zero-order kinetics. Good example is INH and phenytoin. So when you use this combination, the metabolism of phenytoin is decreased by the INH and then results in phenytoin being eliminated differently than it's supposed to, and then gives you the zero-order kinetic elimination. So, mechanisms of drug interactions can be divided into 4 types: the GI absorption, the protein binding displacement, modified drug excretion, and enzyme induction and inhibition. So let's look at GI absorption first. So just some basic principles quickly to guide the following slides. So dissolution is the process where a solid dosage form disintegrates into small enough particles to be absorbed correctly and to get your bioavailability and your effect. And then the site of absorption will also play a key role. Is the site of absorption in the small intestine? Does the stomach act as a reservoir for the site of absorption, or is your drug being absorbed from the large intestine? And then interesting, at least to me, rate versus extent of absorption. So pharmacists really like to tell patients take with or without food, which sometimes hinder patients to take their medication because they feel they didn't eat, so they can't take their medication. But if your extent of absorption is still fully absorbed, the rate is insignificant. So if the food will influence the rate but not the extent of your absorption, you don't have to advise the patient with or without food. So that was also something that was interesting to me. Okay, so in your GI tract, you can get the following interactions due to drug binding: alteration of GI motility, GI pH, intestinal flora, and then the metabolism within the intestinal wall. So first we're looking at drug binding in the GI tract. So drugs with large surface areas result in adsorption of the second drug to the first drug. So a good example is activated charcoal, which is actually the mechanism of action of said drug. Other ones that patients frequently take over the counter is the antacids. We also get formation of insoluble complexes or chelates. An interesting one is the iron salts with the tetracycline, methyl dopa, and levodopa, especially in your pregnant patients, because they have to take iron supplements, and then if they have blood pressure issues, they will be on methyl dopa. So that one is also one that you have to watch out for. And then antacids and cyclophosphamide with the quinolones. And also the binding resins that we use, the cholestyramine with thyroxine, warfarin, and thiazides. And then also interesting, oral phenytoin with enteral feed specifically also affects the concentration of the phenytoin that's available for absorption, resulting in a decrease in effect. So some theorize that it's due to the protein specifically that's in the enteral feeds. Then alteration in GI motility. So gastric emptying is very important for your absorption and bioavailability. So anticholinergic agents delay gastric emptying. So if you require absorption in the duodenum for your effect, this is going to affect your absorption and bioavailability. Sustained release tablets or your enteric-coated drugs, which require more alkaline environment. If you delay the gastric emptying, it might cause premature release of your drug before reaching the duodenum, also affecting bioavailability. And then we get the prokinetics, which increases the gastric emptying, such as metoclopramide and erythromycin, and that affects your dissolution time. So not enough of your drug has underwent the process of dissolution, so there's a decreased quantity available for absorption, which also decreases your bioavailability. So alteration in GI pH is the next one. So drugs are either weak acids or bases. The non-ionized or lipid-soluble form is required to transverse the membrane into the bloodstream. And then weak acids, like acidic medium, and a weak base prefers an alkaline medium. So something that most patients use is antacids, histamine 2 receptor antagonists, or proton pump inhibitors. And all of these drugs increase the pH. So just a few examples how this can affect absorption and bioavailability. The ketoconazole requires an acidic medium for dissolution. So if you have an increased pH, your drug doesn't undergo dissolution properly, which then decreases your bioavailability. Your enteric-coated drugs has a premature release due to the alkaline environment that's caused by the increase in the pH, and then also gives you decreased bioavailability and can also result in some adverse effects, like the enteric-coated aspirin being released in the stomach, which can rather cause an ulcer there instead of passing through to the duodenum. Then the danosine is rapidly degraded in an acidic pH. So it was formulated to take that into account. So when you increase the pH, the danosine does not degrade as it's supposed to, or predicted it would degrade, and then you have more of the drug available for absorption, and that results also in an increase of bioavailability. Then our intestinal flora actually plays a very big role in certain aspects of our drugs that we take. So antimicrobials will obviously affect our intestinal flora. Some key examples, digoxin, which has a small therapeutic index, is actually metabolized somewhat by the gut flora to inactive metabolites and then excreted. So when you have a reduction in intestinal flora, you can actually see an increase in digoxin concentration if the intestinal flora is not there to assist with the metabolism. And due to the narrow therapeutic increase, this is a danger zone for the patient. And also something to consider is the oral contraceptives effectiveness that decreases. And this is due to the contraceptives being conjugated in the liver, then it's excreted via the biliary route, and then deconjugated again in the GI tract via the intestinal flora, and then reabsorbed for effect. So when you reduce the intestinal flora, you decrease your deconjugation capabilities, which then increases the elimination and then decreases your oral contraceptives effect, which is not advisable. Patients need to be aware of that, definitely. And then one of the old bad guys, the grapefruit juice, is a selective cytochrome 3A4 inhibitor. And this specific enzyme is required for intestinal metabolism. So we all know about this one, but it was just interesting for me how big the effect can be. For example, on the phenolipine, you can increase your phenolipine concentration by 270% if you take grapefruit juice with your phenolipine. Just some other drugs there as well that is metabolized by cytochrome B3A4, which if you take your grapefruit juice will also have an effect. So rather skip that glass of grapefruit juice, in my opinion. So how do we avoid these GI drug interactions? So the binding interactions, quite easy. We just need to administer our agents 2 or more hours apart. Something that I think is challenging in a hospital setting, because here we adhere to the 6 to 10, 6, 6, 6, whatever hours rule, and everything is given together. But we can maybe educate the patient when they're going home that they should take their drugs a bit differently and not as a cocktail in the morning or at once. Then we get the GI motility interactions. So unfortunately, this is a systemic response. So separation of drugs is of no use. So it's important for us to manage it. And you can manage it via dose adjustment, alteration in agents, or if all else fails, you have to avoid the combination. So same with the alteration in GIPH. If you are using proton pump inhibitors or histamine 2 antagonists, which results in the systemic response. But if your patient is using normal antacids with a local effect, you can actually adjust dosing times to assist or to avoid certain drug interactions. The intestinal flora, we can maybe look at supplementation or other forms of protection of your intestinal flora. Otherwise, as with the metabolism within the intestinal wall, it's also a systemic response and therefore requires management on a different level with the dose adjustments, alteration in agents, or if all else fails, to avoid the combination. So next in line is our protein binding displacement. So we're going to focus on two proteins, albumin, and then the alpha-1 acid glycoprotein. So albumin has an affinity for negatively charged drugs, so acidic drugs like warfarin, phenytoin, and NSAIDs. And then also to note, in situations of stress, albumin is consumed as a protein. Thus, it drops its levels, and then the free fraction increases of your drug because there's no albumin to bind to. And then the opposite is true of the alpha-1 acid glycoprotein, which is has more an affinity for positively charged drugs, which is basic compounds like propranolol, disopyramide, and lidocaine. And in situations of stress, consumption of this protein decreases and then decreases your free fraction. So if your drug's effect is elicited by the free fraction and you have a drop in albumin, you will actually have a higher effect with your drug, but you will have a lower effect if it is the alpha-1 acid glycoprotein because there's less of the free fraction available. So a good example of this is phenytoin, which binds to albumin. So this was a study conducted where they measured the serum levels, or the total phenytoin levels in patients, and then also the free fraction, and then compared it to each other to see does it correlate. So interestingly enough, you can actually see that here the patient was subtherapeutic, but actually according to the free fraction, which elicits the effect, the patient was therapeutic. So we would increase the dose here because we think that the patient is subtherapeutic. Here even more dangerous, also registering as subtherapeutic, but it was actually toxic levels according to the free fraction level. And then here the patient was therapeutic according to the total level, but toxic according to the free fraction level. So if we look at all of these percentages together, only 44% of the patients were correctly classified as subtherapeutic, therapeutic, or toxic, and 56% were incorrectly classified. So if possible, in cases where the albumin levels are very low and protein displacement is suspected, free fraction determination is rather advised to determine certain levels of drugs. So modified drug excretion, so this will mainly focus on the kidney. So the GFR, so again, digoxin, old client with a narrow therapeutic range. So anything that affects your renal function, like aminoglycoside-induced renal failure, will cause your narrow therapeutic range of digoxin to maybe become toxic. So it's an indirect interaction via the kidney, but definitely something to keep in mind. Then you get active tubular secretion. So an example of that is penicillin is eliminated via active tubular secretion, but probenecid inhibits that process. So then you get a buildup of penicillin within the patient. And then your sodium and lithium tubular secretion. So the lithium tends to follow the sodium. So if you have too much sodium, you're excreting the sodium, you lose your lithium, and then also for the absorption is the same. So, and the lithium levels can have a detrimental effect on the patient. Then we get, apologies, passive tubular reabsorption. So that is the non-ionized forms that are reabsorbed in the proximal and distal tubular. And things that can play a role here is the alkalization of the urine. So then the weak bases type of drugs will accumulate there. If you acidify the urine, then you get the accumulation of weak acids. And then another interesting one was the didanosine and allopurinol. If you use them concurrently, the allopurinol will result in passive tubular reabsorption of the didanosine by almost 312%, which is quite high. And then lastly, dialysis will also affect your drug concentrations. This is just a list of some basic and acidic agents. So if you acidify or alkalinize your urine, these agents will then accumulate accordingly to their preference. Okay, then the last one, enzyme induction and inhibition, and it's always a mouthful because there is so many of them. So just some basic principles. Enzymes act as catalysts, so they turn lipid to water soluble, active to inactive, prodrug to active. Something interesting for me was that the tramadol is metabolized to its active metabolite, and the active metabolite elicits the effect. And then if you decrease the active metabolite, you get a decreased therapeutic effect. So patients who do not have the specific enzyme responsible for the metabolism will say tramadol has no effect on them or a decreased effect on them than what we expect. Where the opposite is true, if you have more expression of the specific enzyme, then you get more metabolism, more active metabolite, and then these are usually the patients that will tell you I'm allergic to this because I'm experiencing a lot of adverse effects when I take the specific drug. And this is where pharmacogenomics actually plays a big role, where we can actually look at the genetic makeup of a patient and see how they will metabolize drugs differently. We are not all the same, which is actually a very interesting field. So metabolism is usually done in two phases. Phase one is oxidation, reduction, hydrolysis in the liver. It's dependent on the cytochrome P450 enzymes as well as its family and subspecies. And this is where we will focus on the inducers and inhibitors. Just interesting, phase two is the glycuronides. So they inactivate certain drugs, which is then rapidly excreted in the urine and bile. And this is also safer to use drugs that undergo metabolism according to phase two in your hepatic dysfunction patients, seeing that the metabolism is happening outside of the liver and not inside the liver like phase one. So our enzyme induction, so we know these four, barbiturates, carbamazepine, phenytoin, and rifampicin. You get very interesting and cool tables, summary tables and sites that have complete lists, all the different subspecies that is affected and how they are affected, that are easily referenced, seeing that it is quite a lot of information. Just important, enzyme induction takes time. So it's not something that happens rapidly. So your onset of your interaction is gradual and your offset as well. So it's not something that's going to happen immediately. So just be aware of it, that it can happen in future and it might take a while for your drug interaction due to the enzyme induction to dissipate. And then obviously it's dose related. So if you use higher dosages, you will get increase your induction levels as well. So enzyme inhibition. So it's more predictable with more accuracy. More studies have been done regarding enzyme inhibition. Also very interesting summary tables and sites that can help with referencing. Here the onset and offset is quicker because it only depends on the half-life of your inhibitor and the affinity that it has for said enzyme. And then also dose-related, high dosages will elicit a quicker effect. And then also just a few examples of enzyme induction drugs. This is a table that I've spoken about that actually gives you a good indication for reference. So it shows you that this causes enzyme induction of this specific cytochrome. This drug causes inhibition, and this one causes induction. And then you can even see auto-induction here with the carbamazepine. So these tables are very nice and handy to have, especially if you need to reference drug interactions. Because in the past, everyone said cytochrome P450, they work on the same system, so they interact. But it's not necessarily true. If you look at amlodipine and amiodarone, they have no overlap. So even though they are metabolized by the same type of enzymes, due to the subspecies of the enzymes that we have discovered now and researched better, you can see that you can actually use these two together. It's not necessarily a contraindication. So, to conclude, as practitioners, we need to predict and evaluate potential drug interactions. If it's unavoidable, we should minimize the risk potential for the patient. Drug interactions follow a predictable pattern in the sense of time course and mechanism, which can assist with the management of them. Potential drug interactions should, however, be evaluated using patient-specific parameters. Not all our patients are the same. They don't take the medication the same. They don't have the same genetic makeup. And then due to the limitless combination of pharmacokinetic, dynamic, and pharmacogenomic drug interactions are inevitable. So it is a challenge to manage drug interactions, but I think we need to think about it differently. So instead of just saying these drugs interact with each other, we can't use them together, we should rather try and classify the interaction. Is it mild? Is it moderate? Is it severe? Is it life-threatening to the patient? And then based on that, we manage the drug interaction. Some patients take drugs for years together in combination. They do have an interaction, but they don't have any complaints. So it's not necessarily a good idea just to stop because on a piece of paper it says so, but the patient has no clinical indication that the interaction is a problem. So it needs to be evaluated patient-specifically, situation-specifically, and then based on that, we decide what we need to do with said interaction.
Baie dankie. That's so lovely. I just having two questions.
Easy ones, please.
Yes, yeah, really extremely easy. One is related to the fact that, I mean, you mentioned very well about the binding, the albumin.
Mm-hmm.
Yeah, and obviously it's critical clear that you have to replace albumin.
Mm-hmm.
But if you look at most of the studies actually showing that giving patient albumin, there's no mortality benefit. The questions that, I mean, if they're so critical in this role, how come these studies are so contradicting, or perhaps maybe those studies were done in patients that actually having sufficient albumin? And when can we actually replace albumin in this context? Is it when it's 80%, 20% reduced, 50%?
I'll just have to check the exact concentration that specific study referenced now. But it was a lowered concentration. So the patients were first classified as deficient, and then they were the phenytoin levels were taken as such. But I do understand that we might be overusing albumin in a sense. So I think it also depends on the drugs that you give the patients. If the patient is not necessarily taking anything that is specifically protein bound, I don't think that an albumin level will affect it. But if there is a specific drug that you do know that is protein bound, you can always then opt to check the free fraction if you're not replacing the albumin and diagnose accordingly or adjust accordingly. So there's different approaches to trying to reach the problem, but yeah, and especially now with the albumin shortage, it is difficult to just replace it. So we have to navigate it a little bit differently. So I would then suggest if you do not replace the albumin, to just then be aware which drugs are affected by protein bounding and then displacement, and then monitoring them according to free fraction where the free fraction elicits the effect.
But I thought also 50% of drugs are protein bound anyway.
But if the
It's about
dosages,
my career.
yeah, but if the dosages, again, if there's no clinical effect, you don't have to mess with it. But if there is a clinical effect, you have to mess with it. I can put it like that.
Yeah. Any question?
So a lot of the drugs are old drugs, like phenytoin.
Mm.
Nobody uses phenytoin anymore. So, which is understandable. But I think the bigger thing is newer drugs, especially PPIs.
Yeah.
Because we write PPIs like candy, and a lot of the medication needs,
Acidic environment.
yes, to be, for instance, iron, all those things. So, are we using PPIs too much?
It's possible. I think it's we have to check why we are using the PPIs. Is it for peptic ulcer disease, or is it for the patient is just having a lovely lifestyle and not doing anything about it and doesn't want to have gastric reflux? So I think we need to educate the patients regarding the use of the PPIs and try to limit it for a shorter period of time if possible. But there are certain conditions where extended use is warranted, where the patients have ulcers or recurring ulcers, or they have certain conditions where they can't go without the PPI. But then those specific patients should be less than the general population, and you can monitor them more effectively. And then increase or
Because I
decrease.
think it's also a cost implication because every patient, because you don't take PPIs every day.
No,
So now if you end up in hospital, you get Nexium every day. It's
Yeah.
not necessary.
No, I think listeners, maybe perhaps we must look at the indication of PPIs in critical care. I think I think sometimes maybe we underestimated the use of PPIs. Now the question that I think there are quite clear indications for PPIs.
yeah,
One, of course, is that anybody with spinal surgery or neurosurgery indicated because the risk of ulcers is quite very high. And the second, anybody who is ventilated on anatropes is absolutely indication for PPIs. And then also patients that are on the oral corticosteroid, because also this indication for PPIs.
yeah,
And patients that probably had previous ulcers and all that, they having that. So now if you look at that, I mean, let's look at our critical care. Our critical care, we have neurosurgery and have most of the pulmonology patients. And of course, most of these patients are really on the oral steroid, I think, because acute exacerbation in the COPD or asthma. So this direct indication for that. And of course, now the spinal surgery, they needed that and all that. But in cardiac patients, perhaps the indication is not, it's a relative indication that is not. So maybe I think what we'll do, maybe next studies, we actually, next our presentation, probably look at the roles of PPIs in critical care, because they're quite, the literature is quite well.
Does it matter when most of your drugs you're giving IV?
Well, intravenously, the question that, again, what are you giving? So now if you have, again, maybe you must reclassify your PPIs. Now, things like pantoprazole, they having really less P40 induction side effects. Okay, so ideally it's supposed to be safer as compared to Nexium, omeprazole, and all of those, they're quite different. But the question is it the benefit outweigh the risk? I think that's where it is. And I think perhaps what we do on our next presentation, we create a proper guideline. I think I've done that when I was in Joburg General Hospital. We look at when do you actually give PPIs. And I remember currently we had one patient who actually went for a spinal surgery, Dr. Maney, and she came to ICU, surgery was affected, and PPIs was omitted, and she had massive bleed.
Yeah.
And she actually demised. I remember her name very well, so it was from the other areas. So I think PPI is indicated, but maybe you need to re-stratify your patients. I think pulmonology patient, good indication. Spinal surgery, good indication. Critical care patient that require anatrop, good indication. But if it's just a pure somebody who does not need any of the above, then it is. But I remember that our critical care currently, our occupants about 75% to 80% pulmonology patients, and then followed by the spinal surgical cases are really down on the floor. We don't really have many surgical patients. If they are not, they're probably less than 10% of critical care too. So I don't know whether that actually answers your question, but I think the choice, when to use Truston,
Does it not also matter whether the patient is getting enteral feeding
it does also matter.
versus
Yes.
parenteral feeding?
Yeah.
So
And-
then you're also including general surgical patients, because some of them have a hemicolectomy, they're not necessarily having enteral feeding immediately or whatever.
But the real that I think feeding is actually the best
Prevention.
prevention for PPIs. Is actually what is protected to your gut. So the moment you can start feeding, maybe you can't actually de-escalate your PPIs. So perhaps maybe we should talk about the duration. When do you actually stop it?
Maybe we should look at all
You know what I mean? So there are a lot of
Yeah.
aspects that we must actually look at it, and then maybe have a nice guidelines. Maybe you can give it for 24, 48 hours. Once your iron drop, stop everything. Patient back to oral nutrition, you stop it, because you also know PPIs can increase risk of pneumonia in the context of the pulmonary. There are quite a lot of studies done on that. Yeah. CD also, and all of the above. Yeah. So I think maybe just to answer your question. So I think for me, it's more about that. The question that do you give PPIs? The answer is yes. Who do you give? Pulmonary embolism, and also, I mean, let's not forget the new oral anticoagulation therapy. It's a direct indication of PPIs. I remember that we have quite a lot of studies looking at the products, looking at the serotonin, everything. All of these patients in the past, what they could have done was actually to make sure that those patients had stool for H. pylori, okay, or underlying gastritis, because the risk of bleeding from GIT was higher compared to the CNS bleed. While warfarin is opposite. Warfarin is having more CNS bleeding compared to a GIT bleeding. So again, I don't know whether before when someone's on the new oral anticoagulation that you're going to initiate, maybe there's a role for you to send the stool for H. pylori, and maybe you do education therapy, or maybe get a proper history, make sure that those patients does not have a risk of bleeding.
Yeah, PPIs are definitely indicated in a critical care setting because you can get stress-induced ulcers. So, so there's a lot of protocols and data indicating that it is a must. But in the general community,
Yeah,
I think, like Dr. Engelbrecht indicated, everyone is on a PPI at home.
it shouldn't be.
So we can maybe reevaluate, like you said, Dr. Tapan, to see when is it really necessary.
I think for Dr. Engelbrecht, I think that's a very important point. Maybe we must work out a strategy how to de-escalate and to stop it, you know. And as I say, once the patient starts feeding, you must stop PPIs. I think for me that would be, and you find patient feeding, going to the ward, after critical care, stop PPI. Maybe we should do that. And maybe we just put in levels for the pharmacist to make sure it doesn't continue. I don't know whether that addresses your concern. What do you think?
It's not concerned. I'm just saying that we have to look at, especially PPIs.
Okay. That's quite a very good presentation.
Thank you so much.
So you did create a very nice discussion. Well done, Francisca. You did it again. Oh God.
Okay, thank you, everyone.
Thank you so much.
Sorry, anybody online for question?
People online.
Any question online? It's coming.
Okay. Thanks, everybody.